mentioned some landmark studies, so I think we can transition into some of the newer ones that you talked about. With PSMA PET, that kind of non-metastatic castration-resistant space disappeared. That was, of course, darolutamide's first indication. They come out with some other ones here. Maybe you have any thoughts on ARASENS trial? That's when they're looking at kind of that combination therapy in that metastatic castrate-sensitive space with chemo and
ADT
and darolutamide.
Plus or minus darolutamide. And it's kind of interesting when you look at that study because it clearly showed a benefit, but I think probably a better control arm would have been docetaxel, right?
Yep.
That's the question we really want to know is what's the PFS plus minus chemo, but instead it was plus minus darolutamide. So, it's still good information, but maybe not as practical as we would hope.
Yeah. You guys have any other thoughts on limitations? What they did great about it? What how easy or difficult it was to bring into the real world when they published that? Because I had lots of issues getting it from my patients initially.
Yeah. Coverage can be an issue, I know, like you said, and I think you look at the package insert, look at the official indication, and and again, it gets back to kind of risk stratifying your individual patients. I know we've talked about that at conference and say, do you want to have the patient get, how much morbidity can they handle, like asthenia? Yeah. And I think the data point, it was 0.68, so it was a clear, significant, it was a definite significant signal there, and in the right selected patient, are they unfavorable and high risk, PSA velocity, all those different disease, all those different features,
Yeah. Personally, I thought one of the things I would have liked to have seen is that risk stratification, that high and low volume. I think a lot of people would have liked to have seen that because we know that Charted didn't really pan out for low volume.
Right.
Piece one actually shows a little bit of promise, not significant, but actually it's still in low volume, and so I think that still remains a little bit of an unknown of what do I do for my low volume metastatic hormone sensitive castrate sensitive patient. That's where I really would like to know. Am I giving them, darolutamide, ADT, plus minus chemo? And I can start the other two and usually kick it off to our med-onc colleagues and have them help us out.
Right.
Any other comments on that today before I move on to ARANOTE?
Interesting observation. How many times do you have the med-onc versus the urologist office starts, the pill? I think it does vary in different settings. You'll see different groups. Some groups do, some don't. So
yeah, absolutely.
So you guys even within groups, you see some partners who do or don't. So
we do a lot of
it. Yeah.
Which is nice.
Yeah, especially on. I just came from our Illinois side of things, and that's regularly partner with some med-oncs there, and it's great working relationship. Yeah.
Which is nice.
Yeah, I mean, we have a team that helps with foundations and funding and all that stuff. So
which is huge.
We've got a great team.
Got to have that.
Yeah.
One thing they mentioned in that trial, I was curious what you guys thought. Is that P90? Where it's like, how significant is that? Are you seeing how quickly the PSA drops? Right, they're using that as a marker for their trial, at least, to say it was effective at getting that PSA down.
It's kind of like
really
when they first started doing radiographic progression instead of overall, and it's like, hey, is this a legitimate surrogate? I don't have a good comparator to say if it's a legitimate surrogate. I don't know if you guys have any data that totally supports getting it undetectable also. I mean, anecdotally, I absolutely buy it, but I don't know that I have a paper that says, man, we need to
because you obviously treat the metastatic, even people all the time compared to us. Is that quickness of PSA response, has it correlated to duration of response?
I think I've seen that in the office. If they get down there and they stay, I mean, I've seen a lot of those guys who do very well for quite a long period of time. So, yeah, I've seen that, which is nice. And how about also interested different? How about your place too, Dr. Strope? Have you seen who does the orals versus just?
Oh, we're all the same.
Yeah, that's right.
So
we
really start
same
off
place. Like you guys are
oral
foundation. Yeah, you guys have the support there. Yeah.
So with ARASENS, got darolutamide approved with chemo. It's very difficult to get it without chemo, and that was a lag. So ARANOTE comes out, and then that's looking at your ADT and darolutamide against ADT monotherapy. So that kind of competes, or not compete, but the comparable trials for the other. It's a crowded space there with med. So Titan, Arches, Latitude. Dr. Strope, any thoughts on how the study was done, feedback on does this fit in right along with the others? What did they do well? What did they not do well?
I think it fits in right along with the others. I mean, I don't see a real major difference on that. It's good to see that it's I mean, of course the drug would be effective. I mean, it's effective with chemotherapy. Why wouldn't it be effective?
Right.
So I wouldn't,
It's frustrating to not be able to give it without chemo for quite some time.
Yeah.
Right. So I think that's going to be the major difference.
Yeah.
And it's well tolerated, so.
Yeah.
The only thing to point out, that was a non-US based study, so that I think had 30% Asian population, which is was unique around in the Midwest for sure.
Yep.
So possibly a little genetic heterogeneity, but still very positive study.
Yeah, and 10% African American, which is higher than the other population ones.
I think there's one going on now in the U.S. I can't remember what is it ARASENS or ARA something?
That one I don't know.
There's a U.S. trial.
Is it real world probably?
I think so.
Yeah. But yeah, I think other notes I had on ARANOTE, just no one had prior chemo, and so not a total comparison. Latitude was similar though, and 70% had high volume disease, and that compared very favorably to the others as well. So I think when you really try to, there's no head to head, but if you're going to at least compare cohorts, was kind of nice to see that hey, this does fit in quite nicely actually. In terms of tolerability, what comments on that compared to some of the others?
I think the class in general, has about like a 0.6% risk of seizure. I've heard that reported, and I've seen clinically, not often, but I do kind of keep that on my radar. If somebody has some seizure disorder history, you might look at the different options that are out there versus, one of the, an abiraterone. But I think at the same time, it's uncommon, it's rare. And so, again, looking at patients, I do always try to tell them as well, with the randomized trials, multiple that have shown the more you can stay active and up and around, you're going to have better tolerability. So I always emphasize that, and I tell them whatever you can do, try to stay active. It's counterintuitive, paradoxic. Even if you're tired, get up, move around, you'll feel better.
Right, sure.
So
I've definitely seen what seems to be very good tolerability on darolutamide. Also less cross-reaction with a lot of those blood thinners, antiplatelets, been easier to give, I think. And then most other updated study would be Piece 3, and this is another study in the metastatic castration-resistant space. Ultimately, it was looking at enzalutamide with radium-223, and if you guys will recall, radium-223 with abiraterone was not beneficial, worse overall survival, more skeletal-related events, and that led to saying, hey, do not give abiraterone and radium-223 together. This one kind of comes back and looks similar, but with enzalutamide. Anyone have thoughts on how the trial was done, outcomes, and how it makes you feel about, yes, I'm willing to give this, not give it, and maybe any pertinent asterisks to how this trial.
If I remember, that was in the metastatic castration resistance.
It was,
space, right?
and so it was a ADT with enzalutamide, and no one prior
They couldn't have
was on enzalutamide, so a unique cohort
Yeah.
against ADT, enzalutamide, and radium-223.
Yeah, because I think there's a lot of studies that kind of get started, and then the disease state moves past where that study was being done. And I think this is an example of that, because you're going to have very few patients who get to the metastatic castration-resistant space and have never seen one of the new advanced
in the real
oncolytic
world,
drugs in the real world. So that's where I think that's where that's going to be tough to see that being used.
Yeah, I agree.
Well, I mean, that's a challenge in prostate cancer in general, is the technology and the development is moving faster than the results can bear.
Yeah. When you're forming these studies, when you're making them, it looks forward thinking, and then when it publishes, you're
of course,
like,
it takes years.
what are these guys doing?
Yeah.
I think a very pertinent point to that study is they mandated bone health injection, or at least bone health care, whereas that was not necessarily true in ERA 223. And so, yes, it appears that you can safely administer enzalutamide with radium 223, still get some benefits. that were quite comparable actually to Radium-223's approval of the ALSIM packet trial. But you got to be on bone health agents. So for me, I think the biggest takeaway was I'll do it, but you have to be clear, either dentally, if it's XG or whatever, before I'm going to sign off on this thing.
And it looked like in both groups, that's why they had no difference in those skeletal events, because they're probably both on.
Right.
Yeah, so which is remarkable. There was no difference on that particularly, which is kind of cool.
If you really
to
focus
see.
on, and I do think bone health gets overlooked a lot, at least on the urology side. I don't know if, it's just, we're so focused on the other parts of the disease status, and they're also talking to us about all the urinary stuff that comes with it, that it does get overlooked a lot, but I think it's a nice emphasis point for, yes, you can do it, but you gotta be thoughtful.
I've been surprised sometimes covering if somebody has known bone metastatic disease and there may not be a use of an Xgeva or Zometa. I'll just think, it's because to me that's absolute routine. Reduce skeletal related events, and I think you get to the safety data as well, which I think is a really good point. Enzalutamide, like in the PEACE trial, and, similar to darolutamide, the safety and the tolerability is really nice to see. I wonder in the future how much we're going to see. Radium-223 versus the newer, lutetium. Maybe I'm segueing into it.
That's literally what I was like, what are the new ones?
A question for the group.
Yeah.
What do you guys do with somebody that's on denosumab and still has osteoporosis on their bone density study? I had that the other day, and I called one of the osteoporosis docs, and she's like, there's nothing you can do.
Yeah, I just tell them, I make sure, they're getting their calcium, trying to take that with meals, make sure the vitamin D level's good.
Right.
And I'll tell them, hey, here's a good, if you weren't taking that, it would be even worse. You know what I mean? So I do tell them, and I try to do DEXs every 2 years, because I always hear them say, do it too often, that doesn't change that much in a year. So, but, try to.
Yeah, for sure.
We wonder about, there's OsteoStrong. Have you guys heard of this? There's a theory that the vibration at OsteoStrong, these little centers around town, there's data on animal models. The vibration really helps build these, like osteoclasts or something. So that's their model.
Is that what they're
Interesting,
doing?
I don't know if it's a gimmick. I don't know, but I mean, it's that there's strong
Did you
data.
do the same by driving the streets in St. Louis?
Yeah, exactly.
This thing hit all the potholes and get lots of vibration.
That's true. The public bus system.
It's funny.